I went in the Air Force in 1968. I worked in the classified area. I left in 1973.
Military service can be pretty hard on people's bodies, and symptoms may not emerge until years later.
I fell 20, 22 feet, something like that. Landed on my feet, had compression fractures from it, but I didn't have any difficulty from it until in the 90s. What happened was I was functioning fine the day before, and the next day when I woke up, I couldn't even manipulate my left hand to attach my pants, buttons, and belt and everything. It was just kind of no power, no strength.
So Mr. Berger has spinal stenosis, which he's had for many years and is progressive. It causes a lot of pain in his back as well as his legs.
I have bad days and worse days. There are no good days anymore.
During the 1990s and early 2000s, medical providers prescribed opioids for all kinds of pain. In 2012, they prescribed opioids for more than 255 million Americans. James was one of them.
They prescribed hydrocodone, and I believe that was maybe 99, 98, somewhere in there.
But it turns out that opioids are nowhere near as safe as the drug manufacturers promised. And that's why VA's now trying to minimize risky opioid use among its veteran patients. Clinical pharmacist practitioners, or CPPs, are spearheading that effort.
So a clinical pharmacist practitioner has a scope of practice, and that allows us to prescribe medications to patients. That's kind of our bread and butter, seeing patients in the clinic setting, prescribing medications, and then managing both the outcomes of the medication and any side effects or drug interactions.
Clinical pharmacy providers have training that is specifically focused on medication management, whereas physicians in other disciplines have more broad training for a variety of medical needs.
Over time, James's chronic pain led to another problem: anxiety.
I mean, I couldn't even be alone in an exam room waiting for the doctor to come in. I'd have to open the door and walk and pace in the hall. I was a mess.
James was given a benzodiazepine called lorazepam to help with his anxiety.
My doctor did what he felt was best for me at that point in time.
Unfortunately, taking opioids and benzodiazepines at the same time puts people at a high risk of overdose.
We've learned that that is a very, very high-risk situation. Opioids themselves chronically are high risk, but particularly when you add benzodiazepines, the risk of overdose and dependence or abuse is quite high.
So these patients can take these medications even as they're prescribed and not wake up.
CPPs use a screening tool called STORM to look for high-risk patients.
So Mr. Berger was a gentleman that we identified via the STORM dashboard who was prescribed both an opioid and a benzodiazepine.
Seems like he's been on lorazepam for a while.
Michaela and Diana decided to talk to James about the risks he faced.
I was an unknown provider giving him a call from the VA and calling to express concern about a medication that he had been taking for a few decades. At first, he was not interested in making any changes because this is something that had worked for him. So why fix what isn't broken?
But after talking with Michaela, he started to reconsider.
Well, I'm a composer, writer, studio musician. My composition, I saw taper for probably the past 10 years, really, to the point where I stopped doing any kind of new projects and new compositions totally. And I decided that it was time to do something, and the only thing I knew to do was to first eliminate the pharmaceuticals.
Initially, he was still struggling a lot with his pain, and he had expressed that he felt like he needed his oxycodone. He did not want to stop. The lorazepam, he said he could see maybe coming off of that one. And part of the reason that I ask you that as well is because pain does have a role in our mental health as well.
Michaela helped James with the benzodiazepine because she specializes in mental health care.
Benzodiazepine is something like Ativan or lorazepam or Xanax or alprazolam. Those medications, when somebody's been taking them for more than a few months, their body becomes dependent on it. And if that medication leaves their body abruptly, then they can have very serious consequences.
That's why CPPs often manage drug tapers.
A drug taper is when you gradually reduce the dose of a medication. It is something that must be approached very delicately, and it requires a lot of attention and a lot of time. So we're often following up with those patients, usually weekly, and staying in contact with them for about a 30-minute appointment every week to make sure that they're tolerating it okay.
Having that individual support staff helping me, for me, it was important not to disappoint them as much as it was to not disappoint myself.
The taper off of benzodiazepines for James actually went quite smoothly. He was quite pleased with the clarity that he experienced, and he told me that he hadn't realized what taking that medication for so many years had done to him. Once he was off of the lorazepam, Mr. Berger started to wonder, well, maybe this other medication could also be causing some of the concerns that I've been having, so it might be worth a try.
At this point, Diana took over the case because she specializes in pain management.
When patients first start to taper, they're really motivated. Especially in the case of Mr. Berger, he wanted to be off the opioids. Later on in the taper, when you start to have the withdrawal symptoms, when you start to have maybe cravings or anxiety that sort of creep in surrounding the taper, it makes you more resistant to change.
As I would reduce the amount of opioids, the pain level would increase. And at first, it would increase tenfold. Just your body reacting to say, hey, stop this, we were fine.
I think every patient goes through, call it the hump, the hurdle, where they have to make that commitment to actually getting off the drug. And that's where the CPP, the mental health providers, we provide support to those patients so that they can get over that hump and complete their journey getting off the medication.
It takes conviction. You have to be able to work through it. And I have a choice of either continuing down that kind of lethargic path, non-creative, non-ambitious, or get my life back. I chose to get my life back.
Yeah, I think there's a lot of coaching there. I think there's a lot of picking out what the resistance is, helping the patients verbalize what their barriers are. And I think that's the case with Mr. Berger. We sat down and said, what's got you going today? What are you worried about? What's your fears? And being able to label those and put those out there really help a patient to better understand and cope with their tapers.
CPPs are uniquely qualified to help veterans reduce their drug use. They have the knowledge, the tools, the experience, and the time to guide a veteran through the process.
The amount of time that we spend with a patient who is undergoing a medication taper is pretty significant. I was meeting with Mr. Berger, weekly. I mean, he would call me, off schedule sometimes too, to just ask a question or to get some reassurance. And that's something that's tough for a primary care provider who has a full schedule in their day to do.
It is very difficult to find enough time in my busy schedule to manage an opioid taper and have the kind of supportive conversations that I would need to have with that patient on a routine basis.
That's where, again, the CPP that has maybe a little bit more flexibility can intervene on those patients and provide that support and provide that reassurance to the patient that this too shall pass.
It's almost like having someone in my cheering for me, and I didn't want to let them down.
James now takes much less medicine than he has in a long time. He's reduced his risk of overdose dramatically, and he feels better overall.
Mr. Berger is now opioid and benzo free. He has noticed an improved clarity of his thought. He told me one night he walked by his piano and was able to just sit down and write a piece of music right there. He said he could never have done that had he still been on the opioids and the benzos. So, for him, it's been a life-changing experience.
Mr. Berger is really almost a different person than when I first met him. He is very productive now in his personal life. His mood is better. He is back to doing things that he loves.
I've watched him become much happier. I've watched him resume those activities that he was doing years and years before I met him, years before he was on this medication combination. Now he's back to composing music and spending time in his studio. And it's been really great to see him regain that creativity.
Once I cleared my body of the pharmaceuticals, it all came back. And now I'm back to doing what I used to do all my life and enjoying it tremendously.
I'm proud of every veteran that gets to achieve their goal. And in his case, I think he's proud of himself. And to me, that's more important.
It's extremely rewarding to be a part of that and to know that I've played a role in making this man's life better.
I love this job. It's a great day to come to work and be able to help somebody, to see somebody like Mr. Berger, after six or 8 months of working with him, to see him reach his goals.
I remember talking with Diana when I had actually eliminated the last opioid. And I asked her, can you put in a lab request so that I can go in and have blood work done to see if there's any residual opioids left in my system? And she was happy to do that. And that was kind of a degree of sorts. My diploma, to have that no opioids after 20-some years, it was a victory.